Welcome. I am Terry Tropin, and today I'm presenting a lesson on CPT's Evaluation and Management Coding for Office and Other Outpatient Services. First, let me introduce myself. I have a Master's in Healthcare Administration Informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. Also, I'm an AHIMA-approved ICD-10 trainer. I've taught health information technology at Montgomery College in Maryland for over 20 years. I've also written books on coding. These books are study guides that summarize the confusing coding guidelines. My books include one on E&M coding, ICD-10-CM coding, ICD-10-PCS, and external causes. These are available on Amazon. First, here's a summary of what will be discussed in this video. First of all, what are the outpatient codes? Which codes are we talking about? And also, we'll go through each of these questions that you need to ask to determine the correct code. Who is the patient? Which set of codes should you use? What's the level of medical decision making? How much time was spent providing the service? And which code should be reported? Finally, the answer. These are codes that are discussed in this video. The first set of codes listed in the Evaluation and Management section of your CPT book. We're talking about 99202, 99215. Now, there are other outpatient services. An emergency room service, for example, is considered an outpatient service. An observation service is considered an outpatient service. Those have their own set of codes. For these codes, 99202, 99215, these are reported using either time or medical decision making. There's, of course, will be, in most cases, a physical exam and patient history, but these are defined as medically appropriate, but not further defined in the guidelines, not how many body systems were touched, how much history was gained. It just says medically appropriate. History and exam are not used to determine the correct code. Before going on, let's talk a little about evaluation and management codes in general. These codes are used to report the services spent examining the patient, document the information a provider needs to determine the diagnosis and/or how to manage a specific problem. Each level of E&M code is determined by the amount of work involved in determining a patient's diagnosis or management. The more work, the higher level of the code, the higher payment. For office and other outpatient codes, the correct code depends on either time spent with the patient or the medical decision making involved. Remember that the physical exam and patient history are medically appropriate. Now, for many other codes, including some outpatient codes like emergency room, the correct code depends on a strictly defined level of physical exam and history along with medical decision making and sometimes time. These will be discussed in a future video. So in this case, we're just looking at office, other outpatient codes. Now we're going to talk about what this medical decision making is later in this video. So these guidelines cover only, that we're going to talk about today, are only 99202, 99215. These are the physician's office, an outpatient clinic, or an outpatient area of a hospital. There are other outpatient codes, as I've said. There's emergency room visits, there's observation codes, rest home, nursing facilities, home services, but these have different guidelines. In addition, preventive services, such as annual visits, may be performed in an office setting, but they have a completely separate set of guidelines. Consultations provided in an office setting also have their own guidelines. Inpatient services such as hospital care, inpatient consultations, those completely separate set of guidelines. And these are the ones that end up with history, medical decision making, physical, etc. So this video discusses 99202, 99215 only. So to determine the correct office or other outpatient code, ask these questions. Who was the patient? Which set of codes should be used? What is the level of medical decision making? How much time was spent providing the service? So first, let's start with who is the patient. These codes have different codes depending on whether the patient is new or established. An established patient is a patient who's received professional services within the last 3 years, either by a physician in this practice or another physician in the same group practice, the exact same specialty and subspecialty. For example, 2 maternal fetal medicine specialists. That would be, you have maternal fetal medicine specialist A and B, regardless of which one the patient goes to, they're an established patient after that initial visit. A new patient is described as one who's never received professional services from anybody in this practice, or was last seen more than 3 years ago, or was seen by another physician in this practice with a different specialty. So if the practice has an obstetrician and a maternal fetal medicine specialist, if the patient is seen by the obstetrician and then the maternal fetal medicine specialist for the maternal fetal medicine specialist, they're new. So notice that the professional service is defined as face-to-face services rendered by a physician or other healthcare professional who may report E&M services that are reported by a specific CPT code. This means that a physician who is asked a casual question at a party about a skin lesion is not providing a professional service under this definition. We can assume that no examination or testing was done at this party. Note the 3-year requirement to go from an established patient back to a patient. At this time, the patient becomes a new patient again. So they may have been seen in this practice, if they're not seen for 3 years, more than 3 years, and they come back coded as a new patient. This is because after the 3 years, the history and examination may have changed, and more time in medical decision making is needed to evaluate the patient. Now, it is not always clear whether a patient should be coded using new or established codes. Here's an example. Dr. A has been seeing Mr. James for years. Mr. James sees Dr. A 3 years and 2 days after his last visit. Is Mr. James a new or established patient for Dr. A? So here we have 3 years, 2 days. So therefore, is a new patient again. So it reverts back to new patient status. Here's another practice. Mrs. Tucker, Dr. A is in a multi-specialty practice. He's a dermatologist who's been seeing Mrs. Tucker for years. Mrs. Tucker then sees Dr. C, an orthopedist in the same group practice. Is Mrs. Tucker a new or established patient for Dr. C? In this case, Mrs. Tucker is a new patient since Dr. A and Dr. C are different specialties. So it's not just a matter of what practice it's in, but what kind of specialties the patient is seeing and how long it's been. So why does this matter whether it's new or established patient? Well, the new patient codes pay more than the established patient because it's more work. They have to kind of start from scratch in developing the data on the patient. The next set of questions to ask is, which set of codes do you use? The codes for established or the codes for new patients? As I said, this is important because the reimbursement for a new patient is higher than for an established one. More work has to be done since there's no record for the physician to review. The physician must ask the history, do a more complete exam, which takes more time and involves more medical decision making. So you narrow it down. First, you ask yourself, is this an established patient or a new patient? If it's an established patient, you know you're going to select a code from 99202, 99205. If it's a new patient, you're going to select a code from 99211, 99215. So that narrows down your choices. The next question is, what is the level of medical decision making? Medical decision making is the mental effort the physician uses to determine either the diagnosis for the patient or how to manage the condition the patient has, what kind of treatment should be used. This is based on the physician's years of education and experience. The codes include medical decision-making, abbreviated as MDM, either as straightforward, low, moderate, and high. The higher the level of MDM in the code, the more work required and the higher the payment. Now, if you're not familiar somewhat with MDM, you need to watch my video, which is only on medical decision making, because as we'll see, this is complicated. The level of medical decision making is determined by 3 elements: problems addressed, data reviewed and analyzed, and risk of complications and a morbidity mortality of patient management. So the problems addressed, what are the signs, symptoms, condition the patient has? The data reviewed and analyzed, the tests, diagnostic procedures, ultrasound, whatever, that are reviewed by the physician in order to decide how to treat the patient or what the problem is. There's also risk of complications, morbidity, mortality of patient management. So how will doing this treatment, what risk is involved with this treatment as compared to that treatment? And is, in this specific case, is that risk worthwhile in order for treatment? So the first element of medical decision making is the number and complexity of problems addressed at this encounter. This refers to the condition, disease, or symptoms that the patient has. So if we look at straightforward level, you have one self-limited or minor problem. It's a higher level if there are 2 or more self-limited or minor problems. It's low. So that moves it from, whether it's 1, it's straightforward, 2, it's low. And then for low, you also have 1 stable chronic illness. And then in moderate, you have 2 or more stable chronic illnesses. So more than 1, again, takes it up 1 level. In high, you have chronic illnesses, but these are not stable. These are severe, exacerbation, progression, side effects, etc. You also have acute uncomplicated is low. You have acute with systemic symptoms is moderate, so that has some problems, it's complicated, that takes it up a level. And then it's high, it's acute or chronic illness that poses a threat to life or bodily function. So you can see each level is a little more complicated, a little more data information to review, more serious. Now the other one is, let's see, this is under moderate. 1 undiagnosed new problem with uncertain prognosis. So they don't know what the problem is. They're not sure how to treat it. They're not just sure what's going to happen. That automatically is moderate. So next look at the second element, which is amount and or complexity of data ordered, reviewed, and or interpreted. This includes test results, results from diagnostic procedures, and other data that are used to evaluate the patient's condition. This element includes 3 categories. Categories over here, and each one of these is a little more involved than the previous one. In category 1, tests are ordered or reviewed. An independent historian, such as a spouse or caregiver, may be needed to provide additional information. In category 2, the data are interpreted. This is more than ordering and reviewing tests. The test may have been performed by another provider, and the physician is reviewing and interpreting the results. Again, the interpretation may require an independent historian. In category 3, the test is discussed with another provider. What does this test mean? How should we manage the patients? How should does this test mean this or does it mean that? So it's much more involved. As you can see, each category is a little more involved than the previous one. The final element of medical decision making is risk of complications, morbidity, mortality arising from management of the patient's condition. So this is from management of the condition, not the condition itself. The level of risk is affected by the nature of illness or the injury under consideration. The definitions of risk are based upon the usual behavior and thought processes of a physician and not specifically defined like the other ones are. This element depends mostly on examples, which are mentioned on the next page. This shows the elements of medical decision-making and how they are used to determine the level: straightforward, low, moderate, or high. So straightforward, we talked about that minimal, 1 minimal, 2 minor, 1 chronic with exacerbation, 1 chronic stable. So you can see that as it goes up, it gets more complicated. So for moderate complexity and high complexity for risk of complications, it works best with examples. So for example, moderate prescription drug management. On the other hand, drug therapy that involves intensive monitoring because it's a drug that has can have severe side effects, that takes it to high. Decision regarding minor surgery is moderate. Decision elective major surgery or emergency major surgery is high. And if there's diagnosis or treatment limited by social determinants of health, that's moderate. For example, a patient who is homeless, a patient who is disabled and lives alone may have social problems that make it more difficult to treat. And of course, complexity, the decision not to resuscitate is automatically a high. And here you have the categories, and here's the short definition of categories again. So for medical decision making, you need to meet the criteria for at least 2 of the 3 elements. And here are examples of that on the next page. So here we have element 1, complexity of problems addressed, is at a level of low. Element 2, the data, is also at level low. The risk of complications, however, is at a moderate level. However, in this example, the level of medical decision making is low because 2 of the 3 elements were met. It doesn't matter that this one is higher. You do it based on 2 elements. Here's another example. This is low, this is moderate, and this is moderate. So because you have 2 at the level for moderate, that's the level that you select. The next question is, how much time did the provider spend providing the service? So time includes preparing to see the patient, any review of the task before the patient comes in, obtaining and reviewing separately obtained history, somebody else took a history, reviewing over that, performing a medically appropriate examination and or evaluation, the time spent doing that, counseling and educating the patient, their family, or a caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals when there's not a separate code for reporting this, documenting clinical information in the record, so typing in the information that you've gained, independently interpreting tests if it doesn't have its own separate code, and communicating the results, and coordinating care with other providers if this is not reported using a separate code. So how is time reported? Well, report time spent providing both face-to-face and non-to-face time personally spent by the physician and our qualified healthcare professional on the day of the encounter. Do not report the time spent performing other services that have their own CPT code. You don't want to double dip. Traveling to see the patient. Teaching that is general but not limited to discussion for a specific patient, so general teaching. And that Also, don't report time spent on activities normally preferred by clinical staff. If for some reason the physician is doing the codes or checking patients in, that's not counted because that's usually done by clinical staff. And remember, you must have that time documented in the patient's record. So here's an exception to all the stuff we've been saying. Code 99211 is an exception to all the guidelines discussed. Its description states may not require the presence of a physician. So this includes services provided by a nurse or other non-physician provider. An example might be a patient comes in, they get a flu shot, they leave. No other medical service is provided. If a physician was involved, do not use this code. Use one of the other codes. Finally, we get down to selecting the correct codes. These codes are selected by either medical decision-making or time. You can see that from the scales. Is it more medical decision-making? Is it more time? So you pick the code that matches the medical decision-making, you pick the code that matches the time, and whichever level is higher is the one that you select. For new patients, the times are 99202, 15 to 29 minutes, and the level of medical decision-making is straightforward. For 99203, remember these are the only criteria we use, time, decision-making. 99203, 30 to 44 minutes, level of decision-making is low. 99204, 45 to 59 minutes, this is moderate MDM. 99205, 60 to 74 minutes, level is high. So 99217 is used as an add-on code. This is for when it goes over this code. When you go over the 74 minutes, you use an add-on code. And this is reported in 15-minute intervals. So if it's more than 74 minutes, you go right to this code and then the add-on codes. For established patients, the same kind of thing, but the numbers are different. 99211, as we said, don't need a doctor, no time established, no level of medical decision-making. 99212 is 10 to 19 minutes, and this is straightforward MDM. 99213 is 20 to 29 minutes, low MDM. 99214, 30 to 39 minutes, moderate medical decision-making. 99215, 40 to 54 minutes, and that's high. And again, if it's more than 54 minutes, you're going to report this code with the add-on code. Notice this is for 55 minutes. The code for prolonged services is different depending on whether the patient is new or established. For new patients, the add-on code 99417 is used if more than 74 minutes are spent with the patient. You use the 99417 for each full 15 minutes over 74. So here's some examples. Patient seen for 80 minutes, you go 99215 and then 1 unit of 99417. If it's for 100 minutes, 99215 and 2 units of 99417. So you get as close as you can, full 15 minutes for the code. For an established patient, the add-on code is 99417 is used if more than 54 minutes are done, are used. So full 15 minutes. So an 80-minute encounter for an established patient would be 99215, that's 54 minutes, and 1 unit of 99417, that's for 15 minutes. 100-minute encounter would be 99215, that's 54 minutes, and then 3 units of 99415 for an extra 45 minutes. Okay, so let's do some practice. New patient seen in physician's office for 20 minutes. The physician documents straightforward medical decision making. So let's use the questions that we've been using. This is a useful way to narrow down your choices. Who is the patient? Which set of codes should you use? What's the level of medical decision making? How much time was spent? So who is the patient? New patient. What are the codes used for new patient? 99202, 99205. So we know that the correct code is going to come somewhere from here. If you look at those codes, medical decision making straightforward is 99202, time 20 minutes, that's also 99202. So in this case, it's easy, straightforward, 99202. Let's look at another practice. Established patient seen in physician's office for 15 minutes. The physician documents low level of MDM. And again, we're going to put in the questions and go down one by one. Who was the patient? Which set of codes? What's the level of MDM? How much time? So who was the patient? Established. Which set of codes? These codes. So you know that the correct answer is going to come from one of these. What's the level of medical decision making? The code within here that's low is 99213. How much time was spent providing the service? 15 minutes, that's the level of 99212. You're going to use 99213. Remember, you use the higher of these two. And in this case, that's 99213. Here's a final example. Established patient seen in physician's office for 15 minutes, or 75 minutes. The physician documents moderate complexity medical decision making. So we're going to, again, who is the patient, which set of codes, MDM, time. So who is the patient? Established. Which set of codes are you going to use? These. So you know the code's going to come from here. What is the level of medical decision making? So we have 75 minutes. So 99215 is the first 54 minutes. That leaves 21 minutes unaccounted for. So we're going to use the add-on code 99417 for additional 15 minutes. That leaves 5 minutes. The guideline states 99417 can only be used for a full 15 minutes, so this 5 minutes is lost. Can't count it. So you have 99215, 99217. So if the time is more than the highest in the category, you can automatically code the highest one and go to 99417, assuming that you have a full 15 minutes. It is impossible to remember all the guidelines for these codes or for any codes in CPT. Here's some suggestions on what to write in your CPT book to help jog your memory. So first you might write in the questions. Who is the patient? Which set of codes? What's the level of MDM? How much time? And then you can, as we did with the examples, go through step by step by step. You might also go to these codes. It's only a couple of pages worth. Circle the time and medical decision-making level in each code. That way you can, your eyes directed right towards it. You don't have to fumble around with it. Circle the note under new patients and established patients for services. X no longer use prolonged services code 99417. So this reminds you to go to 99417. Next to code, particularly since it's not with the other codes. 99417, right next to that, code for each full 15 minutes. Make a note by 99211 that this is a non-physician visit. And next to the heading, office or other outpatient services, write in use time or medical decision making. So that's the end of this lesson. If you have questions or comments, please feel free to contact me. Let me know what you'd like to see, what you'd like a lesson on. I'll try to accommodate you. Again, here are the books I've written on coding. These are available on Amazon. You can go to this link here, or you can just go to Amazon and type in Tropin, Tropin. Please click on my picture to subscribe to this channel. I'm posting a video about once a week, every week and a half, so don't miss out. Thank you so much for listening. I hope to have more lessons up soon. Thank you.